Very good evening, all of you. I am Dr Sidhartha Das. My educational qualification is MD from All India Institute of Medical Sciences and DVT from Safdarjung University. I did my dermatology training from Munich University Hospital and Institute of Dermatology Madrid. At present, I am working as a professor of dermatology in Vivekananda Institute of Medical Sciences, Kolkata. And my major work is on dermatology, clinical dermatology, cosmetology and dermatosurgery. At the same time also, I do a lot of workshops in dermatology, not only in India, also in abroad. And today, my topic will be hyperpigmentation. In India, the commonest hyperpigmentation condition we deal is chloasma or melasma. And another is also post-inflammatory hyperpigmentation. But the real challenge to the dermatologist is chloasma. Chloasma, what is the chloasma? It's nothing but a light brown or dark brown pigmentation on the face. Depends on how we classify this pigmentation. It could be epidermal or dermal or mixed. When it is epidermal, this is very superficial, light brown hyperpigmentation. But in dermal type of pigmentation, this is more deeper level. So it's become much more blackish and very difficult to treat. And mixed type is combination of epidermal and dermal type. How do we, histopathologically or how we can make out whether it is epidermal or dermal or mixed? This we can do with Wood's lamp. In Wood's lamp, epidermal, chloasma or melasma, all the areas were intensified. But in dermal, it is not intensified. In mixed, it will be little bit intensified. This epidermal, dermal or mixed type of melasma can be made out through Wood's lamp. In Wood's lamp, epidermal type intensified. In dermal type, it is not intensified, but in mixed type, it is a little bit intensified. Even if we look into the pigmentation type, superficial epidermal is light brown, but for the deeper is a much more deeper level, so that is much more blackish. And for the mixed type, this could be a combination of little bit blackish and light brown color. This could be centrofacial, mandibular or forehead. And the morphology could be punctate or continuous. This type and these types are very difficult to treat. And if it is a epidermal type, very easy to treat, but when it's mixed and dermal, treatment is very difficult and it's a real challenge to the dermatologist. Most of us, we do treat with our medical topical treatments. Now, what are the etiology, what are the causes of chloasma or melasma? It could be idiopathic, that is no cause can be found. Can be due to pregnancy, due to hormonal changes, some patients with cosmetics, some drugs. So these are the conditions which can lead to chloasma or melasma. Now going for the treatment, it's very difficult to treat. And it takes a lot of time for the cure. Even many a time we could not find the cure. And UV radiation is also another part for the producing this chloasma. So whenever we go for treatment, one thing we'll have to remember that not only treat the pigment part, at the same time also you'll have to prevent the disease. And to prevent suns is also a very important part, because you'll have to reduce or prevent the more recurrence. So you'll have to give proper sunscreen also. So now for topical treatment is the commonest treatment we do come across. It could be phenolic and non-phenolic. During the phenolic, the commonest phenolic medicine is used hydroquinone. Hydroquinone, it gives a very good result, but the major problem with hydroquinone It for prolonged use, it can produce ochronosis, that means bluish black pigmentation. So that is one of the common side effects. It reduces the melanogenesis. Apart from other drugs are also like tretinoin. Newer combination drugs are like arbutin, kojic acid. These medicines can be used in, alone or in combination and can give a result 50 to 60 to 70% of the result. In fact, even many of these topical medicine can give result, but sometimes also, or many a time, we cannot find total cure, and patients are really frustrated with the treatment. So, topical treatment is also one of the major treatment for the superficial type, like already have mentioned hydroquinone, then tretinoin, azelaic acid, arbutin, kojic acid. These are the main topical medicine. This can be used. In fact, steroid also be used, but the major problem with steroid is it gives excellent result, but in latter part it produces a lot of complications. That means steroid induced face damage. This can produces more neogenesis. It can produces more redness and itching and burning sensation. And many a time, many medicines used to have combination with these depigmenting agents like hydroquinone, tretinoin, and steroid. Among steroid, hydrocortisone or fluosinolide were the combination. Earlier, the triple combination was one of the very commonly used drugs, but nowadays we prevent or we don't prefer to go for any medicine along with steroid. It's always better to avoid steroid, and this is a dictum that whatever treatment we go should be topical. If we go for topical, we can go for medicines, topical medicines. Maybe it's a combination or alone, maybe monotherapy or combination therapy without steroid. But some of the studies shows that even for steroid also, like triple combination, few studies have shown that 1 or 2 or 3 weeks we can go for a combination steroid, but after that it should be without steroid. That can good result. But if the steroid is used for longer period, so it produces lot of side effects. That means burning sensation and reversible phenomenon. Once the steroid is stopped, there is a rebound hyperpigmentation. Hyperpigmentation become more. So these are the topical medicines. These topical medicines can be useful, but they are not alone sufficient in some of the cases, or that means the resistant or recalcitrant cases of chloasma. So in those cases, other mode of treatments are also needed. So these are like chemical peeling. Chemical peeling, that means that peels the whole skin, along with not only reduces a little bit of pigmentation, but at the same time also it allows penetration of the medicines in a better way. So it combination of topical medicine along with peeling gives a better result. There are various types of peels are available, and they are like glycolic acid pill or combination pill like glycolic acid, lactic acid, salicylic acid. So this combination of the pills can also give better result. Pills can be used once in a month for 3 to 4 months, along with topical medicines or topical depigmenting agents. How this glycolic acid is one of the safer peeling agent? How it does? It does microscopically produces the necrosis of the epidermis, and new skin appears. That is, the skin becomes more glowing, and at the same time, it reduces the pigmentation. But even peeling along with topical medicines not always give a good result. So, what are the other options? So, recently, couple of years back, the new medicine has come out that is called tranexamic acid. So this, what is the tranexamic acid? This basically, it inhibits the plasminogen activator. So increased plasmin level in plasma. It produces more melanogenesis, at the same time also neogenesis, more vascularization and increased mast cells. So tranexamic acid, it reduces the plasmins, so at the same time also neovascularization and mast cells, so reduces the pigmentation. And This can be used along with a topical agent for longer period. The dose is normally 250 milligram twice a day for 4 to 6 months. Tranexamic acid in combination with topical agent gives at least quite good result, but not always excellent result. At least 60 to 70% or 80% patient for 4 to 6 months along with topical agent gives good result. But before giving tranexamic acid, one should remember, one should be a little bit careful about that. So what? Because this can produces cardiac diseases or like cardiac myocardial infarction, ischemic heart disease, and hypomania. So you should be careful about that. In fact, if possible, before starting this treatment, one can go for prothrombin or other times, and be extra careful when we are using this tranexamic acid for a longer period. My experience with tranexamic acid along with dipeptidic agents give quite a good result. Even nowadays also tranexamic acid topical 2% is also available. Even intranasal injection of tranexamic acid is also available, and that is also giving good result. But even then also, not always. There are some recalcitrant cloasma or melasma. Even that do not give excellent result with tranexamic acid along with other topical agent. Now coming to what are the next? Laser is also another mode of treatment, but one thing is very important: go for the treatment very frequently, use proper sunscreen properly, and I will advise to use sunscreen 3 or 4 times a day, and go for treatment. And it takes prolonged time for the treatment to get it cured, and sometimes also it may not be cured. So you'll have to be a little bit careful about the treatment, and if you get the treatment properly, at least 70 to 80% of the pigmentation can fade away. But one thing you must remember, you'll have to use the medicine for a quite longer period, and use of sunscreen is always a must, even after cure of the treatment. Thank you very much.